Hi, everyone. Welcome to this afternoon session. I'm David Blazes, a Deputy Director of Global Health at the Bill and Melinda Gates Foundation. I'm joined by my colleagues, Alex Pim from Wellcome and Stefan Luders from the Novo Nordisk Foundation in hosting this important session. Guided by our mission that every person deserves to live a healthy, productive life, the Gates Foundation focuses on areas of global health and development such as gender equality, agricultural development, inclusive financial systems, water, sanitation and hygiene, and education. Within the realm of global health, which I specialize in, our focus spans a large variety of projects, mainly combating infectious diseases that many of you know, including malaria, polio, HIV, and TB. And enhancing our control of maternal and child health outcomes. Our efforts encompass a wide spectrum of efforts, from upstream health innovations such as vaccine development to downstream delivery, which is often very challenging, of high-impact health products and services to the world's poorest communities, helping countries expand access to health coverage included. In the session today, we emphasize the critical importance of engaging in discussions around a subset of those, mainly infectious diseases. In our ever-evolving world, where globalization, urbanization, and climate change continue to reshape our landscapes, the threat posed by infectious diseases looms larger than ever before. These diseases transcend mere health concerns. They also pose significant socioeconomic challenges. They disproportionately affect the poor, vulnerable populations. They exacerbate existing inequalities and hinder economic growth. By understanding the complexities of these diseases, we can develop more effective and innovative strategies to mitigate their impact and ensure equitable access to health care for all. Alex will in a moment introduce the three panels for this afternoon. You will notice that each panel covers a complex public health challenge that actually affects all of us. I thought they were very well chosen. To find innovative solutions to these issues, multi-sector engagement is critical, to include the private sector, to include philanthropy. Alex, Stefan, and I represent three philanthropic organizations who have invested in this space for decades, but we look forward to all of you joining in the fight to secure better health for all. In the end, it really will take a village, as we say in the US, to accomplish this. And so with that, I'll turn it over to my colleague, Alex, from the Wellcome.
Good afternoon, everybody. Very excited to see you all here today. My name is Alex Pim. I'm the Director of Infectious Disease at Wellcome. And as many of you will know, Wellcome is a UK-based philanthropic organisation, but seeking to tackle the big global health challenges that face us today. The Wellcome Trust is organised now into 4 programmes. We have one programme focused on discovery research, which funds basic science to understand infectious diseases and other health challenges. And this funds research in the UK and across LMIC countries. But the Wellcome Trust also has taken on 3 strategic programmes focused on 3 areas. One is mental health. The second is climate and its intersection with health. And Alan over there is the director of that program. So if anyone would like to speak to him about that, he's there. And then the program that I direct, which is the infectious diseases and is the focus of today's session. And I think this program, the infectious diseases program at the Wellcome, is really focused on the discovery and development of new interventions to tackle some of the most pressing infectious diseases that face us. We've decided to frame the focus of our research on two large challenges. One is the effects of infectious diseases, effective environmental change on infectious diseases, and the second is an AMR. So two of those will be covered in several of the panels this afternoon. I think it's been it's a great opportunity for us, along with our colleagues at Novo Nordisk Foundation, as well as the Bill and Melinda Gates Foundation, to really showcase some of the kind of research that we think is important to bring these new solutions to these challenges. But it's also very important for us to understand the local context and the priorities that are important in this region. So it's very much a two-way dialogue. And I just also want to thank Tamasek and the PAA for giving us this opportunity to showcase some of the projects we're interested in. So without any further ado, I would like to introduce the session. So we're first of all going to have a keynote speaker to set the frame of infectious diseases in the context of this area, and then we're going to have three panels. The first will be focused on dengue, the second on AMR, and the third on the cross-cutting area of surveillance. And I think what we really want to showcase here is that there are innovative solutions to some of the problems of infectious disease, and how research can really, funding research can really aid the development of these innovations to the impact we want to see. So after that introduction, I would now like to introduce Professor Teo, who is Dean of the School of Public Health at the National University of Singapore, and he's also Vice President overseeing the University's Office of Global Health. So over to you, Professor.
All right, good afternoon, everyone. So it's always a difficult session after lunch, and I was just looking around the audience, and I realized that there is the president of the International Society of Infectious Diseases. So I would try my best to give a pitch that he would grade me at the end of it. But I think if we start off thinking about infectious disease in Asia, I really think about these two terms, unfinished business and new emergent threats that our part of the world is faced with. Because when we start to think about Asia, I suppose it doesn't take much for us to realize that if you take a flight with Singapore as the epicenter, 6 hours around any parts to Asia, you would realize it encompasses about 4 billion people, or slightly more than half of the world's population in the world. Now, with that in mind, if we look at what is the burden of disease in Asia at the moment, and this is data from our friend Chris Murray over at the Global Burden of Diseases, you could very easily see that there is a rising burden in chronic diseases, but the unfinished business of infectious disease remains. And when we think about dengue, sexually transmitted infections, including HIV/AIDS, problems like malaria that still poses quite a big challenge to parts of Southeast Asia, tuberculosis and its drug-resistant version of TB, as well as respiratory infections. This comprise quite a significant burden on infectious disease in specific parts of Asia, because Asia is quite a mixed bag. You have high-income countries where the burden is primarily from chronic conditions, to which chronic conditions actually serves as a way to complicate matters when individuals get infected with respiratory conditions. We saw that in COVID-19, where it is the people with chronic disease that bears the biggest burden of COVID-19. But more importantly, there are many countries still in Asia that have quite a significant burden of unfinished business in infectious diseases. And when we start thinking about new emergent threats, with the mega trends of population demographic changes, of populations migrating to the cities, land being cleared, land users changes, I think this is where Asia remains and will be one of the continent with the highest threats. This is just a picture that I showed about how humans are coexisting with livestock, interacting with pathogens in a way that they themselves might not realize. And I think when we look at the past history of SARS in 2003, all the way to the most recent large-scale pandemic of COVID-19, we will see the signatures that livestock interaction brings to bear to human population health. At the same time, even as we think that we have solutions for some of the existing conditions, such as malaria, such as tuberculosis, drug resistance is complicating matters significantly. And drug resistance, the emergence of drug resistance, somewhat is always much more prevalent in Asia, in Southeast Asia. Perhaps it's because of the way the health systems function. This is just the picture on the right. Actually, it's a picture of a pharmacy in one of our neighboring countries in Southeast Asia, where it is based in a supermarket. You could buy pretty much any class of antibiotics from this supermarket. Testing the quality of those drugs resulted in a finding that those drugs are actually suboptimal. So there is a lot of health systems factors at play, perhaps driving perhaps the reason why drug resistance is emerging in a much bigger and a quicker way in this part of the world. We think about artemisinin combination therapy as a way to treat malaria, but artemisinin-resistant parasites are present in Southeast Asia already. Now, I think when Alex and David talk about the threat from climate change, I suppose if we focus just on the first three bundles at the top, around direct contact between species, geographical range of host animals interactions, as well as diseases thriving in hotter climate. And I can see Asia will be at the brunt of some of these challenges. If we just focus on dengue is now being reported in France, Italy, Spain, and I think increasing reports that some parts of Japan are starting to see local spread of dengue. So there are solutions in the world, as we will see. But when we think about how can we tackle infectious disease threats, there are ways that actually we know what the answers are. For example, we could improve the way that we identify cases at the primary care level. That includes tapping on community or village health workers to educate the villagers, the community, vaccinating or screening for diseases. It could also include the establishment and the training of people for national labs so that we can actually rapidly and accurately diagnose pathogens when they emerge, whether it is new or whether it's known pathogens. And finally, do we even have a systems of tracking to accurately classify the types of diseases that are spreading? Some of this requires quite a bit of investment in the health systems, in health information system, but at the same time, what about how do we start to think about strategies to identify outbreaks that could be happening real time in a community because it's waterborne or foodborne, or perhaps it's an endemic infection such as Zika or dengue. And finally, what happens if it's a large-scale endemic? And we have seen that modeling, the capabilities, the human resource for mathematical modeling has been instrumental in guiding many policy decisions, many investments, and many local strategies in terms of how do we detect an outbreak happening at real time, or to identify the right policy of closing schools, opening schools, when to roll out vaccination, when not to roll out vaccination. A lot of this can be guided if countries and local communities actually have the knowledge on using the right analytics to perform the analysis. I think it's easy to say that now we do have a lot of innovations for preventing, detecting, tracking, or treating people with infectious diseases. But the question then is, if we start to think about the equity issue that David brought up, the distribution of some of this technology, it is not that straightforward. Because in COVID-19, we've already seen that often the solutions, whether it is a vaccine, whether it is the therapeutics for treating COVID-19, they often exist. But somehow it is not about having the technology, but it's allowing the community that needs it most to be accessed, making sure that the policies are in place, and even making sure that the infrastructure as well as the human resource talent are trained in the right manner to allow this. So this afternoon, you will actually be hearing colleagues of mine, as well as international colleagues, talk about solutions and problems to a few issues in infectious disease, around dengue, around antimicrobial resistance, or even on how we survey and track infectious disease in a community. And I think the take home is that you would hear the solutions, but the question then is, how do we actually scale some of the solutions or even bring some of these solutions, be it around human resource, be it around the infrastructure that is necessary, or even guiding local governments on establishing the necessary policies to track and to tackle some of this emergent infectious disease, or even what I talk about, the unfinished business in infectious diseases. So with that, I hope you would have an educational, insightful, and also a thought-provoking afternoon ahead. So thanks very much, Alex and David, for the opportunity to address the room. And thank you very much.
So I'd now like to invite the individual speakers for the first panel, which is really focused on the new solutions for tackling dengue specifically. So first of all, I'd like to invite Professor En Ung, who is professor in the program in emerging infectious diseases and associate dean at the Duke NUS Medical School. So please join us on the panel. I'd then like to invite Dr. Kwok, who is a senior epidemiologist working in dengue prevention and control at the Pasteur Institute in Ho Chi Minh City in Vietnam. Welcome. I'd next like to invite Dr. Scott O'Neill, who is founder of the World Mosquito Program, focused on the elimination of dengue. Please join us, Scott. And finally, I'd like to invite Dr. Kristen Pierce. She's a lead clinical investigator and principal investigator at the Vaccine Testing Center at the University of Vermont. Thank you. So welcome everybody to the panel. Thank you again for coming, and some of you have traveled quite a distance. I'm going to start by asking a few questions, and then I think hopefully we'll have some time at the end to take any questions from the floor. So please think as we're going through anything you'd like to ask. So I think I'd like to start with you, Professor Ueng. Could you kind of articulate really a little bit more detail specifically about dengue and the threat that it poses to the region, and perhaps a little bit about how philanthropy potentially could help us in the fight to this devastating climate-sensitive infectious disease?
Thank you, Alex, and thank you for the opportunity to be here to share some thoughts. It's estimated that there are 100 million cases of dengue each year around the world. And as you can see from the map that Professor Teo showed in his talk, that South Asia and Southeast Asia have got the largest share of that dengue burden, right? Of these 100 million cases, that depending on how they present, it's estimated that somewhere between 0.5 to 5% of all these cases will end up as severe dengue, and if it's not properly managed, 20% will die from the disease. So it's not a trivial problem. If we think about, we've lived through COVID, we kind of understand the impact of infectious disease from a context of COVID. In 2020, more people died of dengue in Singapore than of COVID-19. So that's the disease that we're dealing with, right? So until, and not only is, that's the severe end of the spectrum, but if you do recover from dengue, again, depending on age and geography, somewhere between 10 to 15% of people go on to live with dengue for one whole year. So it is something that we don't fully understand, but we now appreciate that there's this thing called long COVID. There's probably a thing called long dengue as well, but it's something that we don't fully understand. But you can see that the disease isn't just that first 5 to 7 days of illness, but it can last for a long time. And these symptoms include inability to concentrate, poor memory, and we have a surgeon colleague who said that for 3 months he could not operate on the same number of patients that he used to operate before he got dengue. Right? So it is not a trivial problem in the sense that it does affect our well-being, it does affect our livelihood and productivity. So what can we do about it, and which is perhaps why we're in this room. And you're going to hear from my fellow panelists on what some of the solutions. Essentially, just 10 years ago, the only way we could prevent dengue is to try and suppress the mosquito population, and that's all we could do. But now we have new tools. We have Wolbachia, we have vaccines, we have better way of doing surveillance, we have better diagnostic tests. But I want to I want to just make the point that none of these things that you hear, although they are really exciting and great potential, at best, the efficacy is about 80%. But we're dealing with millions of cases. So even an 80% reduction, you're still going to get several million of people with dengue each year. And when you have a bad year of an outbreak, that can still cripple your health system. Right? So the solution, I think, that we need, and certainly where philanthropy can step in, is to basically allow us to show how each of these different tools can be used in such a way, in an integrated fashion, that maximizes their benefits, but minimizing their disadvantages. Right? So I think I'll stop there, and I'll let my fellow panelists tell you more about what they're doing. Thank you.
No, thanks. Thank you very much. And I think the point made about chronic dengue is a really important one, and it's known kind of colloquially in the literature as breakbone fever, because it's often associated with severe pain and aches in the body, and so it has a big impact. But thank you for that great introduction, and I'd now like to move over to you, Dr. Kwok. And please tell us more about the work you're doing on early warning systems that can predict the approach of dengue such that we can respond better. So over to you, Dr. Kwok.
Thank you, Dr. Pim, and it's my great pleasure here to share my point of view and emotion towards the early dengue warning system tools. And we all know that dengue has becoming a global public health concern in the past many years because its significant burden and rapid geographical expansions. Unfortunately, our current intervention now do not allow us to respond to dengue epidemic in time and effectively, because most of the intervention now rely mainly on the index cases that we obtain from a surveillance system. Hence, why the dengue virus could spread widely in the community prior to the detection of dengue cases. Therefore, there is a need of an innovative way, innovative approaches that allow us to intervene to dengue before the emergence of dengue cases or outbreak. And in Vietnam, we experienced many early warning tools in the past many years, and most of them provide us promising results on dengue interventions because they have proven their high accuracies, and they show they're usable in dengue prediction, so that it guides us when and where to implement our intervention suitable, sufficient to the risk populations that do provide us the impact on the reducing of dengue incidence and also reducing the vector populations. However, the application of early warning tools still faced with many challenges and obstacles that we need to overcome to maximize the usefulness of this early warning system. First of all, is that they have to prove their usefulness. So that means that they have to provide the governmental and the local and the end user the evidence that could allow them to accept and sustain or integrate the early warning tool into our routine surveillance system. Through many studies or projects that could provide us the reliable evidence so that we can share among the governmental agencies or the local end user to accept it and sustain it. And the secondly is that the early warning tool need to be improved continuously to meet with the real requirement of dengue intervention, and also to incorporate with all the innovative intervention preventions measure, for instance, the release of mosquito that carry Wolbachia, or the application of dengue vaccine in the risk populations. And I firmly believe that with those improvements and concept, we could maximize the usefulness of the early warning system. And hopefully, I hope that the next generation of early dengue warning system tool that we call the e-dengue could point out because they work with the framework of to provide evidence on the usefulness and the use of early dengue system. And we hope that we can have enough reliable evidence to integrate these innovative approach into our routine activity of dengue surveillance and response. Thank you.
Great. No, thanks very much. Thank you very much for that. And being able to detect early when the dengue is going to arrive is critically important for rolling out the innovations. And thank you for highlighting that. And I now want to move to Dr. Scott O'Neill, founder and CEO of the World Mosquito Program, who is going to tell us a little bit more about a strategy that potentially could eradicate dengue, the ultimate goal. So over to you, Scott.
Thanks, Alex. I lead the World Mosquito Program, a not-for-profit group that's owned by Monash University in Australia. And I've been working for the last 20 years on a new approach to controlling diseases like dengue, not just dengue, but Zika, chikungunya, yellow fever, all transmitted by the one mosquito. And the approach is fairly straightforward to describe, that we have found a natural bacterium in insects called Wolbachia that occurs in around 50% of all insects in the environment. Go outside today, and if you find some insects flying around outside in Singapore, about half of them, different species, will be infected with Wolbachia. The discovery was that when we took that bacteria and put it into the mosquito Aedes aegypti that doesn't naturally have it, it makes the mosquitoes resistant to transmitting all these human viruses. So we've done a lot of work being scientists about testing the efficacy and the safety of the method. But I don't want to bore you with that. If you want, you can look it up. It's easy. It's in the scientific literature, New England Journal of Medicine, etc. We've published in the highest quality journals. But I can tell you some real-world examples of impact we're seeing. So in Australia, I'm Australian, and our work is based out of Australia. 1905 was the first big major dengue outbreak reported in Australia in the city of Brisbane. And it was about an outbreak that really determined the link between mosquitoes and dengue virus. And then what we saw in Australia since then was almost annual transmission of dengue occurring. In 2011, we introduced our method into northern Queensland where dengue transmission occurs regularly. Guess what? There's no dengue transmission in Australia anymore, no local transmission. It's been stopped. We've stopped it. Zero transmission is occurring. That's the public health impact. In Colombia, in South America, we've deployed across the Abura Valley, across 3 cities there, across 1.5 million people. We just reported in the scientific journal Nature recently, we've measured a 95% reduction in dengue cases there. In Rio de Janeiro in Brazil, we've deployed, Rio is this amazing city, it's one of the most beautiful harbours in the world, and it has this massive city around the harbour. On one side of the harbour, Rio de Janeiro, on the other side, Niterói. But it's really just one contiguous urban area, but two sort of municipalities. We deployed originally across Niterói. This year, up to the end of February, there were 17,000 dengue cases reported in Rio de Janeiro. In Niterói, where we deployed, there were 69. 17,000 versus 69. So we have a solution that we think is going to be very impactful. We know it's going to be impactful. We're seeing that impact. And it has a number of interesting features about it. One is you only deploy it once. You don't have to redeploy it. You don't have to vaccinate children every year. You don't have to spray mosquitoes whenever there's an outbreak. You just put it once and it sustains itself. That makes it incredibly cost effective, to the point where economists are measuring it as being cost saving for governments where it's being deployed. So it has the potential to have very large ongoing impact. It's shown to be safe. We've not seen any adverse consequences with it. It's shown to be acceptable to regulators, and it's shown to be acceptable to communities. We've now deployed across 14 countries communities with the methodology, and we're having very large impact with it. But there are some challenges with it because it's completely new. When people think about mosquitoes and disease, they think their first thing is kill them, kill the mosquitoes. But guess what? We're not very good at killing mosquitoes. We've been trying to do it for over 100 years unsuccessfully, and unable to do it sustainably. So, there are a number of features about this method. Its sustainability, its cost effectiveness, its acceptability, that we could potentially have a game changer for dengue, but it requires a whole new way of thinking about disease control. It's not just turning the wheel on a new therapeutic or a new vaccine or whatever. This is developing a whole new wheel. And that requires us to have education. It requires a new way of thinking about policy, and it requires new infrastructure to deploy. But I think a very exciting time to be looking at new solutions to a disease like dengue.
Great. Thank you very much, Scott, for sharing with us some of the impact you're seeing with the World Mosquito Programme. So now I'd like to come to Kristen Pearce. And I'd really like you to tell us a little bit more about where we are with vaccines for dengue, another very important protective potential intervention, and where your research is in really driving this field forward.
Thank you. Thank you for inviting me, and it's an honor to represent my colleagues in Bangladesh, where we do a lot of our vaccine work. I'll tell you just sort of a brief history of the current vaccine. That is the NIH vaccine, TB003, TB005, was developed at the NIH, at the National Institutes of Health. The early safety studies in humans were done in the United States, and the vaccine was shown to be very safe and produced a well-balanced, what we'd say, immune response, so protective response to all 4 different types of dengue. And that's really important because when we talk about the development of an effective dengue vaccine, we want it to produce an antibody or protective response to all 4 serotypes or all types. We don't want it to have more of dengue 1 versus dengue 2. It would be less effective, and more importantly, it could be very dangerous. So the initial studies in the US were very promising. It was then licensed by a pharmaceutical company in Brazil called Butantan, and they put this vaccine into larger studies in Brazil and excitingly found the same thing. The vaccine was very safe and produced a very nice, well-balanced immune or protective response. In 2015, our colleagues at the ICDDRB in Bangladesh contacted us because they were very alarmed about increasing epidemics in the country and asked about doing a dengue vaccine study there with the NIH vaccine. In 2016, we launched what we call the Dengue in Dhaka, or DD initiative, and we started the first vaccine of the NIH vaccine in South Asia. And we enrolled 700 volunteers, starting at age 1 and up to age 50. And it was really exciting. We found the same thing. The vaccine was very safe, there were very few side effects, and it produced a very nice, well-balanced response to all 4 serotypes or types of dengue. We've since done a smaller study in older adults in Dhaka and found the same thing. So we've been really, really excited about this vaccine, particularly with the 2 other vaccines that are in production that maybe have some other issues and safety concerns. This, I think, is very hopeful and promising. I think, though, what needs to be done in order to really prove the potential protective power of this vaccine is a larger scale study involving thousands of people, including probably some more data in children, not because we're concerned about the safety of the vaccine in children, but we want to know the durability or the long-lasting immune response. So how long do they produce protection or antibody in young children? And that's sort of where we are with our next steps.
Great. No, thank you very much for sharing that approach with us. So I think, maybe coming back to you, Professor Ng, I mean, where do you see dengue and climate landing us in the next 10 years? Where do you see the future for dengue? With or without these interventions?
Yeah, so I think there's been a lot of, there have been several studies trying to look at what project the trends for dengue. And essentially the drivers of dengue is urbanization, high human population density, and movement of people, right? So, and all those 3 things are still gonna continue and probably increase with climate change because more people will move to cities for livelihood, building economies. Some places where what would probably be ideal for farming today may not be so suitable with climate change. And so you're going to have a lot of movement of people. And from colleagues in the urban development field, I understand that half of the cities that will exist in the second half of this century have not been built today. So new cities will spring up all over the world. Existing cities will expand in geographic area and in population density. So I think all these are favorable for dengue transmission and dengue epidemics. So I think the trend is that there will be more and more cases. I think right now slightly more than half of the world's population live at risk of dengue each year. It's probably, by the second half of this century, it's going to be 2/3 of the world's population.
Great. No, thanks for that. And with that context, coming back to you, Dr. Kwok, what's your vision, given that context of where dengue is going over the next 5 or 10 years with climate? What's your vision for the impact that you want to see early warning systems? Where would you like us to be in that time frame?
Yes, from my perspective, I think that the early warning system should be integrated into the routine surveillance system. That is the first step that we could use the early warning system tool. And secondly, we could move forward that we integrate the use of early warning system with innovative measures such as the Wolbachia or dengue vaccine, but with the target populations. By this way, we can save the money and the cost of the intervention. And our intervention will be targeted with the risk populations. And with that, I think that there's still a lot of things to do with the early warning system. As I mentioned that now, they prove that they have a high accuracy. That means that they are usable, but they do not have any evidence to show the effectiveness when they apply in the field. For instance, we don't know that with the early warning system, how do they contribute to the reducing dengue incidence? How do they impact on the reducing of the vector populations? And are they accept, and do they accept by the end user, that means the local? And do the governmental agencies agree to use it in the future? So by that way, that I think that now the early warning system tool provide us a very promising results on the ability of predict the outbreak, the epidemic. But what they are lack now is the real evidence to persuade the governmental agency and to persuade the end user to accept and sustain it in the future. And I firmly believe that with the early warning system incorporate with all the innovative approaches, we can optimize the usefulness of the early warning system in reducing the dengue incidence and also prevent the emergence of dengue outbreak or epidemic in the future.
Right. No, quite a vision that for the future. But I think one of the key messages there is being able to integrate it into the public health systems and convince the policymakers and governments to build it in because of the impact it can have. So turning to you, Kristen, similarly, where would you like to see the world in terms of dengue vaccination over the next 10 years? What's your vision there?
Well, I'd love to hope that the current vaccines, that the NIH vaccines will prove as effective as we think they are. But I think, again, we need more larger scale data to actually secure that. As I said, there are concerns with the other two vaccines, so I really think that pushing efforts with the NIH vaccine to get this out on a large-scale basis in Asia will be really, really important and will give us more information down the road.
Great. And Scott, what's your vision for the next 10 years? Where do you want to see us?
Currently, the technology we've developed has been deployed over 11.5 million people in 14 countries. And once it's deployed, it's once and done. It's deployed and then it stays working. And so those people, we can expect to have ongoing protection. In some ways, I liken it to public health infrastructure rather than typical public health intervention. We're building bridges, if you like, rather than administering drugs. And so my goal would be to see if we can get the intervention scaled. It's ready to go from 11.5 million people to 500 million people in the next 10 years. It's an ambitious goal, but through partnership, I think it's an achievable goal.
Great. Well, picking up on that last point you met, Scott, I was wondering if any of the other panelists would like to comment on the importance of partnerships in taking forward new innovations. Would any of you like to make a comment?
Maybe I can start.
Yeah.
I think you're hearing different solutions, and in some ways the need for integration is argued by this place, Singapore, right? So Singapore has had a very long history in dengue control because dengue overtook malaria as the most common cause of death in children from a mosquito-borne disease in the 1960s. And so then the government put in place a very stringent and effective mosquito control program that then led to a period of about 15 years or so where, despite epidemics in other parts of Southeast Asia, Singapore was epidemic-free. But in the 1990s, despite the mosquito control program, outbreaks started to recur, although with a longer time interval than most other places in Singapore because, again, the transmission rate was low. And the reason for that re-emergence of dengue in Singapore, despite the mosquito control, is because immunity levels had dropped because you reduce transmission, right? So it's just like again, coming back to COVID, before vaccination became available, the level of control you needed to impose on society had to be so high that it was almost impossible to live. But once you have vaccination, most of us can then go back to our lives, despite the fact that the virus is around. And so unless we can fully eradicate dengue, which I personally do not think that is possible, then we're going to be able to, despite whatever measures we throw at it, live with some level of circulation. And the only way we can do that is if we suppress transmission, but at the same time keep immunity levels high. So to me, it's not a question of which solution to pick, but how do we integrate for maximal benefit.
Yeah. Anyone else want to make a comment on partnerships in taking forward these solutions?
I was going to say, we think we'd like to go from 11.5 to 500 million people. We're not going to do that ourselves. It's too big an ambition, and it can only be done through partnership. It's going to require philanthropists to be involved, particularly for low-income countries support. It's going to need to involve governments to take ownership. It's going to need NGOs to be involved in last mile delivery together with government. And it's only through those types of partnerships that I think we can really have the impact that we'd like to see. And so I think partnership is the only way forward to get, to be able to deliver on ambition for reduction in disease.
Thanks.
And I think just speaking from our experience working in Dhaka, we lobbied some of the US-based vaccine makers to donate vaccine, and we had a really hard time finding someone to do that. We partnered with one of the Indian pharmaceutical companies who've agreed to donate all the vaccine needed to do a larger scale study there. And I think part of the problem in doing that, and this is, I think, where partnership comes in, is it's really the capacity building and infrastructure to do a large-scale study there that would be so important. Laboratory technique and even laboratory buildup. I think that's one area, just in terms of our colleagues and the work that we've done, where we could see partnership.
Great, no, thanks for that. So sort of leading on from that and coming back to you, Dr. Kwok, I think, where do you see in your program or your solution that you want to contribute to the fight against dengue? What do you see the role of, where can philanthropy or philanthropic organizations help you in taking forward your approach to protecting lives and communities from dengue?
Yeah, sure. We do need a partnership, especially in this phase, because we all know that the government not willing to pay when they do not acquire the reliable evidence of our work. So I think that on the innovative approaches now could provide, I could say that the first step, they could provide a very promising result for the early warning system, for the dengue vaccine, or for the Wolbachia. And from my viewpoint, I think that the next phase, we should cooperate all together and to show the reliable evidence on the effectiveness, on the impact, so we could provide to the end user, to the governmental, many solutions, and they could choose the best solution up to their available resources and ability.
Great, thank you. Anyone else on the panel want to comment and speak particularly to this audience about why philanthropy has an opportunity to investing research to really deliver the impact that we all want to see in the field of dengue?
I think that the opportunity to partner with people outside of our academic centers, at least for me, is a huge opportunity to develop something really amazing. And I really feel like we're so excited about this vaccine or these vaccines, and I feel like they have the potential to save thousands of lives, decrease hospitalizations, and really reduce the mortality of dengue and the global burden of dengue overall. So I think any partnership that would support those efforts would be welcomed, not just by our vaccine, but by any.
For me, I think there's a few different potential roles for philanthropy and what we are doing. One is, low-income countries need support to get access to the technology, and so there's always going to be a need, I think, for philanthropy to contribute to supporting low-income countries. But beyond that, there's something more, and there's an infrastructure that needs to be built for our technology that doesn't exist at the moment. We actually need factories, biofactories, to produce mosquitoes. But, you know, a factory for a pharma product is maybe going to cost you 200 to 600 million to build. Biofactories to produce Wolbachia mosquitoes cost around 10 million. And we need to put them in place so that the technology can be accessed by countries. But not only that, because what we're doing is so radically different to what's been done in the past, we need to actually upskill people, governments, NGOs, philanthropists. The whole ecosystem needs to be educated about the approach and the new technology and how to utilize it most effectively. And so we need a combination of all of these things, and I think philanthropy can contribute very significantly to helping set the stage, if you like, for the adoption and take-up of the technology globally so that it can be applied to around 500 million people in the next 10 years. There's a key role there, I believe.
Yeah, I mean, I think I share a lot of the sentiments that has been expressed. I think that nothing quite speaks of, or at least advocate for action like a demonstration, right? So, I mean, if you can show, for instance, the world kind of watched with trials that went on with the vaccine and Wolbachia, and when the Wolbachia trial data came out from Yogyakarta, it was remarkable, right? That it was as good as a vaccine, and this is just by introducing this bacterium into the Aedes aegypti mosquito in Yogyakarta in Indonesia. And that got the ripple started from there. And I think the same thing can be done in sites around the world, because not every place is like Singapore, not every place is like Bangkok, not every place is like Dhaka, and our ecology is different, and how well these things work may depend from place to place and population to population. But if we can have a series of small sites, particularly in those places that are less, that's less able to afford some of these tools, then one is that we will be able to show how well these things can work either on its own or in integrated fashion. But two is a direct benefit to them, because they would otherwise be the last to receive any of these interventions because of the cost of these programs. So I think there's a real opportunity, and of course certainly education, right? Not only from the public all the way through to the government, but also to be able to deal with anti-vaccination or vaccine hesitancy, to be able to educate them about how these things work, and as well as how can you live with mosquitoes and not kill them, so that by so doing you actually protecting ourselves from disease. So some mindsets will need to be changed, and that can only come through education.
Yeah, and I think sometimes, it's hard to understand why philanthropy should be investing in this area where it, apparently should be the responsibility of someone else. But I think the challenge is these types of interventions are for countries that don't necessarily have the resources to develop the tools they need for the problems and solutions like dengue that affect those countries. So I think on that perspective, what do you have any perspective? Does anyone on the panel have a perspective on that, or potentially on the bottlenecks to the particular interventions that you're trying to develop? Perhaps Dr. Kwok, you'd like to comment on that. Why governments aren't investing, and what are the other bottlenecks that need to be overcome?
I think that the crucial limitation is that there are many obstacles in the mechanism of the investment. As I remember that on the first day, the keynote speaker of philanthropy mentioned that there's something that the philanthropy can do, but the government can't do. I think that with some restrict regulations, it will restrict us to do what we want to obtain, what we want to carry out in the field. So I think that with the support from the philanthropy, we can do on our technical terms. But we in the next phase, we do not pay attention to every single innovative approach, but we could invest them all together to have a comprehensive investment and partnership, not only for the early warning system, but also for other innovative approaches like the vaccine or Obamacare. With all together on the field, we can bring back the evidence so that the government will consider and provide us a new mechanism or new regulation that allow us to apply these innovative approaches to pursue the proactive dengue prevention as the call from WHO. That's it.
Great. Well, thanks for those comments. I think we have a few minutes left, and I'd really like to open it up to anybody on the floor who has a question. If you would like to just put your hand up, so one of the people here will bring a microphone. Oh, over there. If you could just introduce yourself before you speak, that would be great.
I'm Sumitra from Mumbai, and we have a huge dengue problem there as well. I wanted to know a little bit about long dengue and why haven't we spoken about it in so many years?
Yeah, I can answer that since I spoke about that. I think the when dengue became a public health problem, it was mostly in children. Right. So for a while now, and if you go to old textbooks, dengue is described as a pediatric disease. But that's no longer the case. I mean, in Singapore, 90% of our cases are in adults, and that's certainly true in many parts of Asia and Latin America. And I think dengue in adult present a slightly different problem. They are less likely to develop that, the severe dengue, the hallmarks of severe dengue. But they are also more likely, however, to experience these long-lasting symptoms. I think Alex talked about this breakbone fever as being one of the names for dengue. If I can go back a little bit, the name dengue came from a Swahili word which means to be seized by a spirit. It just describes the pain, right? Something is squeezing you, and in some parts of the world, it's called breakbone fever. But if you go back to the very old literature, where dengue caused outbreaks in North America because of the slave trade back in the 18th century, Benjamin Rush coined the term break heart fever to describe dengue, because a lot of the people who recovered from dengue continued to have this long-lasting depression. Right? So I think the reason why it's not been well described is because for a long time, it was mostly a pediatric disease, and this condition is more prevalent, perhaps, in the adult population.
Hi. Just in response to what philanthropy could contribute, how they could contribute to dengue, I'm just thinking most of you have a lot of work, other work not related to dengue elsewhere, be it infrastructure, water supply. But while doing this, I think it's important to put the dengue agenda in it. As Eng Yong has said, as Dr. Wee has said, many of these urban buildings, urban cities are being built at the moment. And so while we build, can we have deliberately think of dengue or Aedes-borne diseases with the intent to build it out? For example, your infrastructure shouldn't contain water receptacles to contain water, or water supply should not have stagnant water and things like that. So while you work in your project, I think it's nice to keep dengue in mind. Put the agenda of dengue in your project. Thanks.
No, very good comment. Thank you for that.
Hi, I'm Taslim Arif Syed from CCAM Bangalore. Very good session. A question that I wanted to ask Dr. Christine is about in the current efforts for vaccine development, people are attempting multivalent approaches as well because of the post-single exposures of vaccine. It has become much more sometimes fatal, the second exposure of that. Just want to understand what are the, while your effort is going on, what are the global best efforts in terms of dengue vaccine and how far they are in terms of multivalency?
Tell me if I don't answer your question. That's a great question. All the vaccines are multivalent. All the different pharmaceutical companies and developers that are looking at developing a dengue vaccine, all three of them are multivalent, so 4 different types of dengue. The problem with the other 2, and again, not saying that our vaccine is perfect, but just the problem with the other 2 is that they are predominantly one serotype or one type of dengue, predominantly a dengue 2 or a dengue 4, and don't offer that well-balanced protection against all 4 serotypes. And we've seen with one of those vaccines that there were serious safety concerns related to that. I will say before the NIH vaccine was put all together into a tetravalent formulation, so all 4, they did serial immunizations of a dengue 1, then a dengue 2, then a dengue 3, then a dengue 4, to ensure that the vaccine was not inducing more enhanced disease or potentially leading to the more severe complications of dengue, and we did not see that. Does that answer your question? Okay, thank you.
Yeah, I think for people not more familiar, if you're infected with one strain of dengue and then you get a second infection with a different strain, the disease can be more severe. And that's one of the challenges about vaccinating or developing new vaccines. So I think we have time for one more question. If there are any from the floor.
Hi everyone, thanks for the informative session. My name's Ami, and my question to any of you really is in Asia, I think when we talk about from the philanthropist point of view, the conversation is currently, going into a direction of toggling between a trust-based approach and a more strategic impact investment lens approach to tackling the problems of the day. So from the perspective of dengue prevention and mitigation of its effects, what are the opportunities that any of you are currently seeing with philanthropists? What kind of philanthropic profiles are most inclined to kind of go into a joint venture with you on things? And what do you see in that space happening for you?
Well, I could say that we have a number of supporters that range from big philanthropy, like Alex. Thanks, Alex. But through to families and family offices that want to have impact. I think we all want to have impact at the end of the day. That's what it's about. And we've found that individual families actually have made very large contributions, very generous contributions. The Tahir family in Indonesia very quietly has funded the whole randomized controlled trial that ran in the city of Yogyakarta, just out of their family office, very quietly, not wanting a lot of recognition, but wanting the satisfaction of the impact they've generated from that. And so, my sense is there's a broad spectrum of people, and what ties it all together is the desire for impact.
Yeah. Well, I think we've run out of time, but I think that's a very good point. I think some philanthropies come from successful family business ventures where R&D and the development of new technologies within those contexts actually resonate very well in the R&D for health. And so I think there are different ways of potentially engaging with the dengue innovation. So on that note, I just want to say thank you all very much for your contributions. Great session. And we have a 10-minute break now. There's some refreshments over there, and then we'll be on to the next exciting panel. So thanks all for your participation.
Alex, can I jump in and just say that if anybody in the audience wants to know a little bit more about the World Mosquito Program, my colleague Thierry Scholl, just here, is very eager to talk to you. Unfortunately, I have to leave very quickly, but my colleagues will be here. Sorry, Alex, for that little last.
And I think in the break, it's an opportunity for you all to come and talk to the panelists and find out more about the opportunities. So, thanks and enjoy your coffee.
So, welcome to the next part of this session, where the topic is AMR. Also known as antimicrobial resistance. A better way of explaining it is infections that cannot be cured or very difficult to cure. If it's a topic you have not been acquainted with before, I promise you this is not going to be pleasant. We're going to talk about a threat that is growing. And my name is Stefan Lüders. I'm from the Novo Nordisk Foundation. We're a foundation out of Copenhagen, Denmark, working locally and internationally. Our vision is to improve the health of people and also the health of the planet. I'm not going to trouble you with all the areas that we work in, but it's quite broad. And within health, we're working both with infectious diseases and with non-communicable diseases. And under this umbrella, we are also very concerned about AMR, as it's called. And we share that concern with Wellcome and the Gates Foundation that is also hosting this session today. And thank you for the PA for the possibility of having this discussion today. So with me, I have a very distinguished panel of experts. Each will also present a bit about the work they're doing on this topic in a moment. First of all, I have Dr. Mo Yin sitting here. She is Deputy Director of something called Advance ID, Advancing Clinical Evidence in Infectious Diseases. So she's an infectious disease physician and scientist at the National Hospital in Singapore. So welcome to you, and thank you for coming. And we also have Dr. Taslim Sayed. He's the CEO for the Center for Cellular and Molecular Platforms, also called CCAMP. It's established as an initiative by the Indian government. And I think many of you also know Paul Tambaya. He is a Singaporean doctor and professor of infectious diseases. He is also the president of the International Society for Infectious Diseases. So let me just warm you up on this topic of AMR. So any of you imagine that you would go to, let's say, your dentist, and you would have a root operation, unpleasant as it might be. It's kind of pretty simple. You go home again, and suddenly it doesn't feel so good because you've got an infection out of this. And so you go back to your doctor, and you're being prescribed some antibiotics for this, but it doesn't work. So it gets worse. And you get some new antibiotics, perhaps, and it gets worse, and you get hospitalized. And you probably have an infection with antibiotic-resistant bacteria. It can happen to anyone, and it does happen randomly, not to everyone, luckily, but in every country around the world. It's a problem that's getting worse. It's not getting better, and I'm actually a very positive person in my view of how the world is progressing. Things are getting better overall, despite all the troubles that we are dealing with. But in one area, it's not getting better, and that is in the topic of AMR. It's getting worse. If you go back time, 80 years back, something happened that basically revolutionized the healthcare society. That was the introduction of antibiotics. So with the introduction of antibiotics, we actually had a tool that could cure simple infections that otherwise could really be a serious threat for health. And over the years, antibiotics has saved many hundreds of millions of lives, and it is today the basis of our healthcare system. Without antimicrobials, antibiotics, we are having big troubles having a healthcare system. I don't know if we can have a slide over to the next one, if that's possible, or I can control it here myself, perhaps. I can try. Maybe I can get a bit help. Can someone put it over to the next slide? Yeah, it's happening. So I have, and the next one, please. So if you look at this problem on a global basis, then the numbers are staggering. I think you can read the numbers also yourself. But what we're talking about is on an annual basis about over 1 million people is dying directly from AMR, but more than 5 million people dead annually associated with AMR is probably more realistic. And these numbers are probably heavily underestimated. Half of this is accounted for in the Asia-Pacific region. And if you look at the estimation, because this is getting worse, then by 2050, we're talking about maybe 10 million deaths annually. And by the way, this will be in a population that is decreasing because population rates are going down. So the problem is real, and it's hurting, addressing children, elderly people, and people with chronic diseases. It is a bigger problem in low and middle income countries, but it's also a problem in all countries together. You see a rise in numbers everywhere. And the essence of the problem is that we are running out of antibiotics. No real novel antibiotic has been introduced for the last 25 years. So those that are here are overused, both for human and for animals. And bugs are getting more and more resistant towards these antibiotics that we have on the market. And no new ones are being introduced. So it's just simply mathematics. You can see we're running out of it. And if you look at the company side, the industry side, what is the pharmaceutical industry doing? Well, there is no economy in actually developing and producing new antibiotics. And we know that also from our own foundation, because we created an impact fund with $150 million to invest in companies. And since we did that 5 years ago, then it has gone worse. So industry is leaving the area, scientists are leaving the area, because there is no future in developing new antibiotics. So this is a problem we need to address, and we have to do it fast, because it takes time to get new antibiotics into the market. So you can see I'm really trying to create an optimistic kind of feel in this room. So with that, I will ask each of the panel to use some time to present what you're doing in this topic. And we'll start with you, Morten.
Thanks, Stefan. Good afternoon, everyone. I took care of a patient some years back. It was a 60-plus-year-old uncle who had kidney failure. He underwent years of hemodialysis 3 times a week, but very little complaints. Can I have the next slide, please? And he waited 10 years for a kidney transplant. I remember his family being so happy and excited that they decorated his room, his hospital room, with balloons because they thought that his suffering was finally coming to an end. However, unfortunately, 1 week after his surgery, he started having high fevers, and that was because of a bag of pus that developed around his new kidney. Next slide, please. We found 3 bacteria in the pus, and unfortunately, all these 3 bacteria were resistant to all available antibiotics we have. And we ended up giving him highly toxic antibiotics over weeks to save his life. However, these antibiotics were toxic to his new kidney. He survived, but his new kidneys did not. Unfortunately, these stories are becoming increasingly common in our hospitals. These infections not just affect patients with sophisticated surgeries, but the newborns, the elderly, patients with diabetes, fighting cancer, and the critically ill in the intensive care units. And these patients only form a very tip of the iceberg. Even in Singapore, where antibiotics are tightly regulated, we found that 1 in 4 community dwellers, such as you and I here, carry superbugs or antibiotic-resistant bacteria in our gut unknowingly. And one day in the future, when we become vulnerable to these bacterial infections, we may also succumb. Antimicrobial resistance is really a driver as well as a symptom to inequities in our healthcare systems. And the massive number of deaths that Stefan presented is a manifestation of that deep-rooted issues in our healthcare policies as well as systems in Asia. And yet, most of us remain unnoticing. We are not noticing and paying enough attention to this issue. And how do we solve this problem? Of course, the tip of that pyramid that we need to climb to solve the issue is to optimize treatment, perhaps finding a new antibiotic. However, we cannot climb to the tip of this pyramid without first addressing the foundation of it first. And what's in this foundation are fast and accurate diagnostics, are prevention measures such as improving hygiene to prevent transmission of this bacteria across patients, and also keeping count of the patients that are suffering from these infections and where they are occurring. And this is the precise strategy of Advanced ID. We are the largest network of hospitals and healthcare institutions in Asia. We have over 60 hospitals in countries including China, India, Vietnam, Indonesia, Thailand. All these countries combined, as Stefan has highlighted, has 2.5 million deaths, which is half of the global deaths associated with antimicrobial resistance every year. And how is our work reflective of that strategy? Every week, we are including more than 100 patients across the network to understand how antimicrobial resistance is affecting our patients' health and also the amount of cost that's costing the healthcare systems locally. We are strongly advocating for and supporting education and training in healthcare workers in the local study sites to recognize infections and promptly diagnose these infections. And also, we are teaching them how to do better hygiene to prevent infections going across healthcare workers to patients to family members. And also, we are partnering with industry partners to bring new technology to the local hospitals. For example, a typical microbiology report may take as long as 5 days to reach the patient. But now we are using a new gene-based technology, and we introduced that to the local study sites to cut that time short to as short as 2 hours. However, even despite we have these ambitious plans across entire Asia to improve our patients' lives from these antimicrobial resistant infections, we face a threat in terms of sustainability of our network. These activities, such as preventing transmission, building up diagnostics, and surveillance projects, are the areas that we receive the least funding for. These are the critical parts of our network, but why are we receiving the least amount of funding is because, it's not surprising, it's because it's more profitable to invest in a new antibiotic, which may give you some returns, but investing in a new microbiology lab may not have the same monetary returns in the future. So hence, we are here to get your support to build that core foundation for our network together, to build such sustainable network together. For example, for 250,000, we can easily fund a laboratory in the local study sites, including lab technicians and simple equipments for over a year. And for 100,000, we can build up infection prevention and control policies in intensive care units in the hospital. And these are low-hanging fruits for saving lives. And remember, just a mere 10% reduction in mortality across Asia is equivalent to reducing 100,000 deaths per year, and alleviating a great deal of suffering with that. Thank you very much.
Very good afternoon, everyone. Let me begin by thanking organizers, all three foundations, for the invite. I'm delighted to be here. I just want to largely present to you and possibly build upon what Stefan and Mo has mentioned already, the global threat that AMR is. It's a real biggest threat, and what I'm trying to present is that how we want to do it from the global south, the LMICs and others, and how we want to make it a combined effort, a synergistic effort to actually fill the gap that is happening in global south in terms of the final addressing of the issues like AMR. I'll try to use it myself. Yeah. So CCAMP is very quickly an organization, as Stephen mentioned, and supported by Department of Biotechnology, Government of India. We are largely a catalyst organization, enabler organization for cutting-edge life science research and innovations to ensure that the science is there to solve problems further. What we are doing is that we are building science-based solutions from the ground, and now we are seeing the fruits of it and realizing how it has to be a double game, double engine to ensure that the global best innovations and local innovations come together. This slide you may have seen it multiple times, but what you see here very clearly is the dark blue and the magenta color or purple color is actually where the LMICs reside, and that is the biggest vulnerable countries that we have in AMR. But as we know, the threat is global, and we have to address it there. What are the challenges there in the global south? Because of the nature itself, it is genuinely a global problem, both in high-income countries and low-income countries. We know that. But very importantly, while the global best innovations, which are built on amazing science, they are serving globally, but they haven't been able to completely address the multifold, peculiar, and contextual AMR problems, LMICs, because the setting is different, the context is different. It is not the same sophisticated settings and challenges which are there. On the ground, this is different, and we are talking about possibly billions of people living in those settings. Hence, there's a huge need to actually encourage local innovations, which understand the local settings, which has the local intelligence, which understands the limitations. The global best haven't been as effective in some times, and how do we combine the effort together? That's what we have done it for 15 years at CCAM now, and we are actually seeing the large setup that this hub, which would be a regional AMR innovation hub, which will inculcate and foster innovations locally based on global science, but understanding the local problems much better, and how it will work with the global best science scenarios and building on the contextual AMR challenges to work with the, and answer and complement and synergize with the global best. Over years, there's a broad number of innovations that we have supported from CCAM. These are more than 400 innovations we have supported, not in AMR. In AMR, we have almost 60 odd in total. But this gives us our ability to really support real breakthrough science-based efforts. Not all of them will be successful, but they have to be supported. We are also the only one AMR accelerator funded by CARB-X for the last 5 years, only one outside the North America and Western Europe. Very clearly, we are building a regional-based capability for AMR innovations. We already have 60, but I'll give you a representation of innovations that we are supporting. First one is BugWorks, which is in the phase 1 for broad-spectrum antibiotic. Amazing work. Hopefully, they will go further and get to the next level. Really solid work on small molecule. Gangagen is on the phage-based effort for a small peptide, which actually hoping to get in phase 1 as well very soon. This will be really remarkable. We have many in therapeutics beyond this. This is just a representation. In prevention, I think we mentioned, very important to build preventions. The bottom one, the VAP Care, is only FDA-approved device for prevention of ventilator-associated pneumonia that happens when a patient is ventilated. This is the best Commonwealth Innovation Award across all Commonwealth countries. The Z-Box upstairs prevents TB issue in terms of the environments in ICU and makes ICU very, very sterile in airborne pathogens. Real phenomenal work. Clinical setting publications are out to demonstrate its effort. We heard about diagnostics. We have diagnostics which are SpotSense for neonatal sepsis, module for ID and AST, and RapidX, where we are able to get the phenotypic AST within 5 hours in total. These are, again, representation and something really exciting happening together. Of course, we are building global collaborations. As you can see, we are funded by CARBEX. We are working with GARDP. We are working with Swissnex. We're working with many other things. This is bringing in together while building in the global innovations. So we are here because of phenomenal support by several organizations, including ones in the room, like the BMGF has supported us, the Novo Nordisk Foundation has supported. We are working with Wellcome in many other fronts. Rockefeller Foundation, many others have supported us for building this larger effort. If I were to summarize, we strongly believe that AMR presents global biggest problems, particularly in LMICs, and the problem is peculiar. You have to be on the ground to solve those problems because some settings are difficult settings, remote settings, resource-limited settings, and you will have to build innovations after understanding those problems. And this is where the global collaboration will happen, the global best and the local best could come together, and those innovations can go to other countries. These ready-made innovations which are now in market from India, we are already going to other Asian countries and Africa. And I think I'm here to actually build a partnership with you all to see how we can build such a regional AMR innovation hub which can work together with you and address AMR issues in LMICs, but also in other sophisticated and high-income countries. Thank you very much for your attention. Thank you.
So thank you very much for inviting me to this presentation. Like Mo Yin, I'm a clinician. And one of the questions that has troubled me has been this question about, I started my career in infectious disease almost 30 years ago, and we were troubled by AMR. And we really, to be honest, haven't really made very much progress. We've done so many efforts trying to get people to use antibiotics properly, trying to get people to wash their hands. And I ask myself, are we asking the right questions in antimicrobial resistance? So again, I'm an infectious disease clinician. I spend a lot of my time looking after patients. And this is a young man that we looked after. He had a traffic accident overseas. He had severe head and chest injuries. He was brought into a local private hospital, and his heart stopped. He had CPR done, 15 cycles, and he was revived. They decided to bring him over to Singapore on a ventilator. Until he could be stabilized and transferred safely, he kept getting episodes of fever. And every episode of fever, they slapped on another antibiotic. And the main reason is that hospital was good enough to save his life, but they did not have the microbiology capabilities to identify which bacteria he was infected with. And because of this concern about AMR, by the time he came over to us, he was essentially on 6 different antibiotics that covered every single known bacteria that at least we know about. He came to us. He had the benefit of good diagnostics and a state-of-the-art microbiology laboratory. We were able to stop all his antibiotics. When he did get an infection, within an hour, within a day, we knew what he was suffering from, and we treated it appropriately. And eventually, he did well. He was walked out of the hospital a couple of weeks ago. So I think the first thing is trying to understand, as Mo Yin pointed out, what people are infected with. So we don't just treat everybody with everything. We target therapy, so that way we reduce the amount of collateral damage. The second thing is this issue of understanding the clones. And I'm glad to see some genomics experts in the room here. And this actually came about from a clinical trial that we did many years ago. And it was together with David Patterson, who's leading the Advanced ID Network, of which Mo Yin is the deputy director. So this was a clinical trial studying treatment for an antibiotic-resistant pathogen, and we randomized patients into 2 different arms. And initially, we thought that most of these patients would be patients who had been in hospital for a while, had gone through surgery, had been exposed to a lot of antibiotics. But what we found to our surprise was that most of these patients were patients who were coming in off the streets. And then, and in fact, interestingly enough, most of them were men who had prostate biopsies. And this is what I call a rich person's problem. They go for executive physical, they find a PSA that's slightly high. Somebody says they need to get a prostate biopsy. They get a tablet of Cipro, and it doesn't work. And then we discovered that it's because the infections they were carrying were these superbugs that, again, Mo Yin talked about. So Mo Yin was involved in the study, and what she did was she mobilized a bunch of medical students who were doing a project in YY's department, and she got them to knock on doors in Clementi, offer people $10 supermarket vouchers to give us a sample of poop. And it's amazing that people will do that. And she found that 25% of these people were actually carriers of multi-resistant bacteria. And interestingly enough, these people, the biggest risk factors, number one, was people who had lived overseas for a period of time. And number two was people who actually finished their course of antibiotics. The people who didn't finish their antibiotics had a lower rate of resistant bacteria, which goes against everything that we've been saying. So, of course, being a good scientist that she is, she took it one step further, and her master's project was to identify what was the strain responsible for this, and it was ST131, which is a global strain of antibiotic-resistant E. coli that nobody to this day has actually nailed down exactly where it comes from. I've seen some small papers blaming the chickens, but we blame chickens for everything. So I'm not totally convinced. And finally, because we have this situation where we really, to be honest, academics have really not done a great job in trying to nail down the questions or the solution. We have to depend on crowdsourcing or getting information from everywhere. And this is my plug for what ISID's one of our programs, which is ProMed. Now, ProMed is, for those of you who do not know, it's actually the only human-curated infectious disease surveillance program. So basically, if you go to our website, it looks like something out of the 1990s. It's really, really old, And basically, the way it works is we have a website. You can, if you think something unusual is happening, you can send an email. We send a return email to other people in the country. If we get 2 people who say that something really is happening, we write to the Ministry of Health, and then we give them some time to reply. And whether they reply or not, we put something up on ProMed. So, of course, we antagonize a lot of people along the way. But that's been the way in which we've recognized SARS in 2002, MERS in 2012, and actually a ProMed post on 31st December 2019 was the first alert about COVID-19. So we have ProMed AMR, which is funded very generously by Wellcome and other funders. And I think that is the future. Is actually just listening to physicians, to patients, to microbiologists, to people all over the place, trying to tell us what's going on and trying to put all that information together with good laboratory work and genomic surveillance. Thank you very much.
Thank you very much to the 3 of you. Very, very interesting. And I have, of course, prepared a couple of questions, right? But I will start out just giving, one question, and then I'll, at the same time, also invite you also to ask any questions. I know we have a very qualified audience here, so help me to make this conversation really interesting. So, anyone that has working with AMR know how complicated the whole setting is about AMR, right? We're having to do with structures about how we make food, right? Have animals and how we live, and the Asia-Pacific region is huge, and there's very different conditions you have in various countries. But nevertheless, let me just ask you this very open question, and it goes to all 3 of you. And I'm improvising because I didn't write that down already. But so, and that is, if you should have like 1 or maybe 2 wishes that can actually, come true in terms of AMR, what would you really wish for?
Great. I'm glad you asked. I'm a huge believer in rapid diagnostics, and for a long time. Lots of companies come to me, they tell me they've got this diagnostic or the other, and I tell them, is it as good as a pregnancy test? You go to a 7-Eleven, you pay $10, you pee on a strip of paper, you get a result which is 99.999% accurate, and for some reason we can't do that. We've gone very close to that with COVID. And I think that's one of the huge the huge sort of positives that came out of COVID is you talk to an 11-year-old kid in Singapore, they know how to swab their nose and put it into a thing and take a picture of that and show their teacher and say they don't have to go to school because they've got a strip which is positive. So if I had a wish, it would be that anybody who has a fever or thinks that they have an infection, they could get some kind of rapid diagnostic, and they would know what they needed to treat with antibiotics and what they didn't need to treat with antibiotics, and if they needed to treat with antibiotics, what antibiotic they should treat it with. So that's my wish.
I think that is a very good answer. And I mean, you're welcome to say the same thing, but you don't have to. You could just say you agree, and then you can come up with another wish.
Okay. So let me follow that. I completely agree. Very important component. No, I had 3 of those on the plate there. But coming back, I think for AMR, the other 2, so rapid detection so that you can give appropriate and not wrong antibiotic is very important. 2 other things which are very important is prevention, right? I think it's very important that the emergence or occurrence of such superbugs do not happen. And that requires a significant work, which begins with reduction of overuse of antibiotics, not only in humans, but also in agriculture, animals, and aquaculture, which is loaded like anything else. For that, many things have to happen. Antibiotic stewardship has to happen, but also you have to provide alternatives to agriculture farmers, animal farmers, and aquaculture farmers so that their cohorts or their animals or their shrimps do not get infections. They are doing it because they have to save them. So that's a prevention thing, very, very important. Second is the treatment. I think you mentioned that 80 years back, magic happened. The antibiotic era started. We are actually coming to a post-antibiotic era where most antibiotics are not working anymore. What we immediately need is new antibiotics, which are broad spectrum, which are working. There is a market pool that you talked about. These are 2 very important things that we need in addition to this so that we can A, reduce emergence of new superbugs, and B, if they are there, or not even superbugs, we have the antibiotics which can resolve it, and we don't need to use it every day because that's what is causing that. Thank you.
Thank you very much. And Mo, your turn.
I completely agree with those answers. Coming back to the reason why we are here, right? There are diagnostics available, and there are easy preventive measures available, like cleaning our environment. And I think, of course, it's really important to invest in innovations, and such as rapid diagnostics or machines or drugs that can solve the problem. But with Singapore as a good example, in our ICUs here, our mortality is less than, or the proportion of patients who die from these infections is minimal. But if you go across the region, just cross the causeway or within 1 hour flight from us, the deaths from these type of infections can be as high as 40-50%. Why is that? In our current state. Yeah, so I think if I have a wish list, it would be political commitment to recognize that antimicrobial resistance is the 3rd killer in the world right now. We need more attention to training and education. And I'm really glad there's 2 high-level meetings planned at the end of this year by both WHO and UN to really highlight this problem. But what we can do as individuals in this room is to work from ground up to support the education and training on how to use existing technology to improve our patients' lives. We can already start, going beyond waiting for the next technology or the leap. Yeah.
Thank you very much. So I'm looking out towards you. If there anyone that would like to ask a question or has a comment? No one really? Right.
Hi, really enjoyed the talks. I'm Paul from Duquesne, US. I was just wondering, I guess, Taslim, you talked a little bit about phage therapy in your presentations, and it really does address AMR at a much more fundamental level, using a completely new old paradigm in some respects. But I was wondering if you could talk a little bit more about that and where you see that going. Thanks.
And maybe also explain what it is.
Okay, so largely phage therapy is a bacteriophage. These are, the natural...
It's a virus that eats bacteria.
Exactly, right? It's a natural way, the virus, which is specific to that bacteria. Hence, you do not...
So you actually give a virus to kill a bacteria?
Yeah, they are naturally present.
Yes.
Right? Now, because you are doing specific things, it doesn't build kind of resistance to other bacteria. And that's a specific nature, that it will not have resistance to other bacteria, which is good. But to go to the next level, people, instead of giving viruses, now they are just using virus mechanisms, the bacteriophage mechanisms. That's the peptide which they are using to actually attack that. So you would not have that peptide work in other bacteria at all. It's a very specific bacteria to the virus to bacteria molecular interactions which will cause it. And hence, it has a phenomenal opportunity because standard chemical-based antibiotics have the problem of resistance that will occur. But the bacteriophage peptide-based ones would not have that problem once they go through. There are several efforts in the globe, across the globe, which are doing it. They're growing fast. And the reason I brought out the entire thing is that we need to continuously support these innovations in prevention, in diagnostics, in treatment, and so on, to ensure that these innovations eventually save our lives much better. And these are the efforts which are risky, but got to be supported, I would say. Does that answer your question, by the way? Yeah, thanks.
Yeah. Anybody else? Well, then I have a question. We're also talking about alternatives to antibiotics, and that's where there's happening also a lot of research development for the moment. But whatever is invented needs also to be scaled up and needs to be affordable, right? So how do you see that also philanthropists and funders can help on this area? Is because this can be quite costly, right? If you want to do it. So what do you think are the most low-hanging fruits? You talked a little about better diagnostics at hospitals. What else can you do in kind of accelerating the better use of antibiotics?
Yeah, I think this has to be approached on two levels. On the first level, the low-hanging fruit, as Moyen pointed out, we already have in high-income countries a lot of resources. So it's a matter of getting these resources out there. And so this is where, organizations like Taslim's organization do that. They get them out into the field so that everybody has access to the same kind of results, and they will get the same kind of results that you'll get. So, and this actually has an impact on on philanthropists who like to holiday in exotic locations, because it's obviously in your interest to make sure that in every setting where you are, that at least you can be sure if you get hit by a car, you're going to be treated, you're going to be successfully treated, and you won't get an antibiotic-resistant infection. So you won't get pus draining out of your leg for years, which has happened to some people. So I think the idea of distribution and ensuring that capacity is built up in every setting is critically important, and many people have recognized this. So that I think is the low-hanging fruit. The higher one is actually understanding the whole philosophical and scientific concept behind antimicrobial resistance. And this is where I've argued that we tend to be very, in a way, egotistic, and we think that antibiotic resistance is the creation of human beings, and that we created the problem, we can solve the problem. But in reality, there have actually been studies done in uncontacted tribes in the Amazon jungle, and they go there and they test them and they find antibiotic resistance genes. And you realize that humans are actually kind of peripheral to the world. It's actually a battle between bacteria and fungi. So you know the famous story, right? If Alexander Fleming left the window open, the mold came in and killed the bacteria. So that's what molds have been doing for millennia. Fungi have been killing bacteria. Bacteria have been evolving to fight fungi. So I think what it means is we need to better understand this whole idea of, the relationship between the bacteria, the fungi, the viruses. And we are starting to scratch that with this idea of the microbiome or the mycobiome, and understanding that, we have all these living things on us. And it's just disrupting the harmony that makes us sick, that gets us antibiotic resistance. And there was a Michael Crichton story from 40 years ago where they had developed the perfect antibiotic. So they had developed this perfect antibiotic, tested it on animals, they gave it to the first human being, he died within a day. Because bacteria make clotting factors, bacteria are part of our body, they keep our skin healthy, they keep our intestines healthy, and they do all kinds of things that these microbiome people claim that they do. So I think that's the difficult part, but it'll be really exciting.
So I think one of the things in general we know, and I think we heard in the introductory panel when the entire context was set, AMR as a space, and you also mentioned, isn't very lucrative from a market perspective, but it's projected to kill 10 million people per year, 2050. That's crazy number. And we need to have solutions to do that. Now, if the market pool is not there, investors are not putting money into innovations. People, as you said, the organizations are going to. So we need to actually support that setup. This is at the global stage, but you now come to LMICs, where many of these markets are even much more weaker, much more broken. The innovations for those are going to be even more challenging to build. And I think we need to build systems because at the end of the day, this is going to be more than half of the population of the world, or even more, which is actually getting affected. But market is not good enough for investors to come in. So we cannot let people die just because market is not there. And hence we have to build innovations locally so that we have to put in those resources now to save the global lives going forward. And that is very, very important to happen. It has to happen across the value chain of the innovation so that those solutions which succeed, not all will succeed, but those will succeed, will save lives eventually. And that's very, very important.
Mo?
Yeah, I think there was an excellent question just now about how to strategize investment in terms of philanthropic donations. And perhaps we can view it in two aspects. One is a horizontal aspect where I was talking about building up capacity in terms of improving hygiene, education, and teaching. Perhaps these may be viewed as we don't get solid numbers back. We are just building capacities, it's a long run kind of an investment, but we don't have a solid number to tell me that my investment was really worth it. But these are critical activities which I was trying to highlight. But another approach that I think that's very relevant here is to invest in a particular diagnostic or a particular antibiotic. So I can give you another story. I visited Medan in Indonesia, and one of the last line antibiotics that we have, which I showed earlier in my slide, that we had to give to our patient that's highly toxic to the kidneys, is called polymyxin. And this is the antibiotic that's given to pigs in farming, widely used in China and all that. And they even banned the use of that because they realized pigs started to have resistance to that. And that is the only treatment, the backbone treatment we have for highly resistant bacteria in our ICUs these days. And if you go to Thailand or anywhere, I would say half of the patients would be on that antibiotic. And when I tell my Spanish colleagues or European colleagues to say half of our patients are on that, they get so shocked because these are the antibiotics they use in farming. And when I went to Medan in Indonesia, they asked me, how do you treat this type of infections? I said, unfortunately, we have to use polymyxin. And they told me, they don't even have polymyxin. This is the kind of inequity that I was trying to highlight across the world. So how do we get governments or ministries to invest in building up, to approve these antibiotics or to bring in these antibiotics, to invest in diagnostics? We need better evidence to show that they save lives, firstly. And secondly, we need to show that they save costs for our healthcare systems at a population level. So if you would like to invest in a particular product, I would say diagnostics or new antibiotics, to build up the evidence to convince policymakers that this is the right way forward. Because there's so many conflicting priorities, and this is what we can do again from ground up to show that this is worth it for our government leaders. Yeah.
And there's a very good lineup over to concluding the session because we are running out of time. So on that note, I'll just say that, this year is especially important in terms of AMR because at the United Nations Grand Assembly meeting in September, AMR is one of the key topics. So this is a very good opportunity for countries to really say, well, now it's time to make radical decisions. It's not something that just one country can handle. This is just like COVID, an area where we need to have a collective decision, and it has to be rooted in the governments and the political leaders, because otherwise you won't see the investments and the changes that are necessary to tackle all the AMR challenges in the future. So I really cross my fingers for that meeting, and that will be really a change. That change will happen at that meeting that will have an effect on the whole world. So on that note, I will say thank you very much for the panel, and now we'll have a little break until the next session. Thank you.
Okay. So our final panel today is on disease surveillance, and I am joined by three esteemed colleagues who will join me here in a second. So Dr. Ruki Dialwas is Deputy Director of the Center for Outbreak Preparedness at Duke NUS. Dr. In Li Ching is the Group Director of Environmental Health Surveillance at the National Environmental Agency in Singapore. And Dr. Basil Rodriguez is the Senior Regional Health Advisor for UNICEF based in Bangkok. So thank you for joining us. Okay. I think this is a really fitting final session today. We talked about two really important diseases or disease states in dengue and antimicrobial resistance. So how do we know those are problems? How do we know if a vaccine or an antibiotic works? And not just for individual patients, you can see the outcome in an individual patient, but across populations, the way we know those things work or if a disease is a problem is through surveillance. And that's what the topic of this last session will be. How do we innovate in surveillance? How do we improve surveillance, to improve health across populations? So surveillance, in many ways, is the basis for understanding health across populations. I think many of us learned the value of epidemiology and disease surveillance during the COVID pandemic. I think we all learned how we can find a new variant. We learned how to relate that to clinical and epidemiologic data. And I think that it became very clear that some countries did this better than others. I think we all aspire to be those countries where we understand diseases in a timely fashion and can implement control measures in a timely fashion. We're not all there yet. I think many countries, including my own, did very poorly in response to a pandemic. So I think that this session will touch on some of those challenges, touch on some of the innovation that we see going forward. And I think we'll touch on some opportunities for philanthropy and others to contribute to disease surveillance. So with that brief introduction, I'll ask our three panelists to talk about their work in disease surveillance. And we'll start with Ruki. So Ruki, you work here in Singapore, but your work extends to many countries in the region. Can you tell us a little bit about your work?
Of course. Thank you, David, and thank you for inviting me here. Before I start talking about my work, I kind of want to take us on a bit of a memory lane. It's probably not a memory lane most of us want to remember, but end of 2019, December, many of us on the news, we heard of unknown pneumonia cases, right? It was a few cases. The first time I saw this was on Twitter. My husband was dragging me up to Everest Base Camp. And I'll be honest, as an infectious disease scientist, I was terrified. I was messaging my colleagues, infectious disease colleagues, and they were worried. Why were we worried? Because if it's an unknown pneumonia, a pneumonia of unknown etiology, that means we have no idea what it is. We don't know how to treat it. We don't know how to stop it. How do we do any of the response actions? How do we save lives? But then towards, let's say, first week of Jan, I don't know if many people remember, the sequence of the pathogen was released. It was shared to the rest of the world. And that was known as SARS-CoV-2, and we knew the sequence. And 48 hours after that sequence was released, we had PCR, so molecular PCR diagnostics. That was in-house at the time, and then obviously later on there were pharmaceuticals companies making actual diagnostics. Now that really revolutionized the way we tracked SARS-CoV-2, right? We could then ask the question, do we have it in Singapore? Or do we have it in the US now? Is it just contained to a region in China? We soon began to realize it was in Singapore a couple of weeks later. It was in Thailand a couple of weeks later. Then we began to realize, as David said, There were new variants coming out. It was evolving. Now, one of the things that SARS-CoV, the pandemic did, and the same way it did for mRNA technologies, it really pushed a technology that's known as next-generation sequencing from the research sphere. You know, many of us scientists, we were sequencing before. For a couple of years before, we were using it in the labs. But it was for the first time that it was, in a big way, pushed to public health use, to really save lives at a population level. And COVID did that, the pandemic did that. Second thing the pandemic did was, and this really relates to the work that I'm doing right now, it pushed this technology, when technologies usually take decades to go from a high-income setting to a low-middle-income setting, it really pushed the technology quickly to low-middle-income settings. And that is sort of where our work comes into place. So towards the end of 2021, Bill and Melinda Gates Foundation recognized that our Asian region, obviously we have countries of various capabilities and economic status. We realized that many of the countries didn't have the ability to sequence. They didn't have access to next generation sequencing. So we needed to do something about it. So the initiative known as the Asian Pathogen Genomics Initiative was set up, and that is the secretariat for that initiative lies with us at our center, but really it's an initiative that works with about 14 countries, all of them low middle income. We have about 50 partners now, many of them sequencing pathogens for public health use and really working with their governments, or some of them are governments, to inform and to see what they can do about outbreaks. Now, one of the first activities that we ended up doing was a landscaping. And the reason for that was during COVID, there were donations, there were of equipment, people were mobilizing, trying to train individuals, countries were trying to get this new technologies on the ground. But we really needed to know if Asia PGI were to work with our partners on the ground to strengthen pathogen genomics, then we need to see where were they, the baseline. So we did these surveys at the national level with 13 countries. And what we found out was that all of those countries, for some part, had next generation sequencing capacity on the ground. But clearly, it wasn't very much for some countries. It was very little. They had just adopted it. They may have one or two individuals in an entire country who could actually sequence a pathogen. So they needed a lot more improvement. The turnaround time was slow. All the way from diagnosing, essentially getting a sample from a sick patient, to getting the sequence out, it took them 3 to 4 weeks. And that's far too slow if it's whether we're talking about clinical management or outbreak response. We also found out that in terms of financing, cost was an issue. Majority of the financing for this work in many of the countries, about 60% of it, came from external sources. So there's an issue of financial sustainability here. Then we looked at policies. Are there guidelines and policies in the countries where they can guide their public health officials, their scientists, the laboratory individuals to follow? Are there guidelines, policies for genomic surveillance and the use of this technology? But there actually wasn't. Only 30% of the countries had some guidelines. So really, the work that we're doing at Asia PGI, we're working both at the ground level, so bottom-up approaches where we're doing a lot of training. We're trying to get individuals trained to be able to do sequencing and use that information for not just tracking pathogens, but also for other purposes. That sequence information can also be used to design diagnostics, to design vaccines, etc. So we're looking at the whole entire use of pathogen genomics. The second is we're also taking a top-down approach, which is working with governments to ensure that there are policies put in place. So, and there's an infrastructure put in place so that pathogen genomics can be maximized public health utility. And that's sort of, I think I'll end there because I think David has quite a few questions. But just to point out, you know, in LMIC countries, in high-income countries, about 25% of fevers are undiagnosed. But if we're talking about low and middle-income countries, this percentage goes up to 90%. But technologies like NGS can make a big difference in really trying to diagnose what these etiologies are and then using that information for treatment.
Thank you, Ruki, and it's great to see the progress on your initiative and so many countries involved and great partnerships. So so it was actually interesting to hear both prior sessions talk about kind of an ecologic approach to both diseases. So whether it's the vectors and vaccines in dengue or the microbiome in AMR. So that ecological approach and approaching surveillance from an integrated perspective is really, really important. And, you know, I think Li Cheng has incorporated that into her work, you know, at the National Environmental Agency. So can you talk a little bit about that and maybe focus a little on environmental surveillance as that's becoming a new technology?
Yeah. Thanks. Thanks, David. I'm Li Cheng coming from the Environment Agency. I come from a program. Mainly, we do a large part of our job is to control dengue and other mosquito-borne diseases. So in terms of surveillance, I think there are maybe four main uses. You mentioned about burden of disease, understanding the burden, understanding how effective your tools are. If you don't have a ruler, you don't know what is the impact of your investment. Also, the third one is about outbreaks, alerts to an outbreak. I think the first panel mentioned about can we have an early outbreak, a warning of an outbreak so that we can prepare for it. A fourth one would be to guide vector control, to guide in terms of dengue or anything, or any diseases, is to help you to focus on certain areas, especially when you have good resolution spatially. No program in the world can have enough resources to cover the whole country at all time. So you need to be able to focus, a risk-based approach. So I think different surveillance tools serve different purposes, but I personally would like to promote an integrated approach, taking a One Health integrated approach to surveillance. Typically, when a disease is detected in human, if it is a very explosive kind of outbreak like dengue, like COVID, we've seen it, it's usually too late by the time you get into an outbreak situation. For example, for dengue, by the time you get an outbreak, you will have a lot of people infected with mosquito, you have lots of mosquitoes, and you have infected mosquito. So the number of infected mosquito that can drive transmission, the way that they accumulate is going to be faster than the speed that we can kill them, we can destroy them. So early response is very important for us. And because of that, in NEA, we have put, for 20 years now, we have put together an integrated approach. Firstly, of course, looking at cases, and that's under Ministry of Health. Thanks to rapid tests, we talk a lot about rapid tests. Since 2008, we have been using this antigen testing, which has really helped us a lot in early response. We had our time lapse from onset of disease to response by our NEA officer going onto the ground. We shortened it from 7 days to 3 days. So it's quite significant because of good diagnostic tests. Secondly, is viruses. So since 2005, we have been tracking dengue viruses in Singapore. About 20 to 50% of our cases are sequence or genotype. So because we know that if we have a sudden accumulation of certain variants, or there's a switch in a predominant serotype, it's a signal for outbreak. So we use that as part of our outbreak, our situation outlook. And of course, when it comes to dengue, vector surveillance is important. We have 70,000 traps, or in-house design traps out in the field, telling us where mosquitoes are, and this guide our vector control, and at the same time, the information is on website. If you go to our website or you go to My EMV app, you will see where are the areas with high mosquito population. I think the intent here is to mobilize people. It's a social mobilization. Act before dengue comes into your area. So taking an integrated approach covering the 3 guilty parties of dengue, I think is important. So putting all this data together, you can do data analytics, you can do projection with climate, with satellite images and all that, so you can get a very good picture. And all this, of course, also has been very useful for our evaluation of Project Wolbachia. Similar, but not the same with what Scott has been doing. We've been using Wolbachia, but we use a suppression approach. Our intent is to press down mosquito population. So all this surveillance system has been very useful. It has served us very well for Zika as well. Because Zika is transmitted by the same disease, same vector. But Zika, in addition to all this system, we have a wastewater system, wastewater-based system to track Zika. Because Zika is shedded in the urine of patients. In fact, its urine is an excellent diagnostic test. Since 2016, we hypothesized that it's possible to use wastewater to track Zika. So 2020, because of COVID, we put in place the wastewater testing. It has been really very nice for COVID. We use it for Zika recently. After in COVID, we had a little outbreak. We validated that it was good. And then 2 months ago, we sent an alert in another area. It was based on wastewater testing and mosquito testing. We alerted the public of transmission area because despite having just 1 case. And this is especially important for Zika because most cases are mild or asymptomatic, so it will likely most cases will go under the radar of clinical surveillance. So it is very important, but though it's mild for most people, it is very critical for pregnant women to know Zika because of the condition, the neonatal condition. About 5 to 20% of people, of pregnant women, of the babies, could have a condition, including microcephaly. So we're excited about the use of wastewater surveillance, set up for COVID, where we showed very nice trending, very nice correlation with the cases. Today, with very little testing for COVID now, we continue to sustain that 500 over auto-samplers around Singapore, sampling sites. We're still monitoring COVID, not just for sudden surges in cases, but also the variants that is in circulation. So we sequence from the wastewater for variants of COVID. So that is exciting, I think, from the environment perspective. But I think One Health I cannot talk about One Health without talking about animals. I just want to emphasize also about our program under One Health. We have different agencies working together. Just want to draw another example of One Health approach. Recently, we had leptospirosis, a rat-borne disease. It's carried by rats among dogs in a neighborhood. So that was alerted by our MPARKS colleague who are in charge of animal health. But they alerted us and alerted MOH, Ministry of Health, and together we went in to co-investigate and took actions together. So of course they took care of the animal health, MOH would take care of the human health, and we went to survey the sites and to catch rats, survey for rats and test it for rats, and also work with stakeholders in the neighborhood to look into waste management, especially food waste management, and cleanliness and housekeeping. Mm-hmm. So in conclusion, I just want to highlight the importance of a One Health approach in surveillance, taking environment, health, and environment, human, and animal into consideration, and leveraging technologies and innovations as we move forward. Thanks.
Thanks, Li Ching. That's really well said. And so we've discussed some innovations, right? Some innovations in next generation sequencing. That's a technology that has shown great promise and is being distributed in many lower and middle income countries. I think integrated approach to surveillance, including One Health, including wastewater surveillance, I think there's enormous opportunity there to bring that innovative approach, to disease surveillance as we go forward. And so I'll move to Basil. So Basil, you've worked in public health for 4 decades and have seen a lot in this region and around the world. the technology innovations are wonderful, but it often comes down to policies and human relationships to make surveillance work and for surveillance to lead to action on the ground. So whether it's a vaccine or policies. So can you give us your experience there and what we might look to the future?
Thanks, David. And I want to thank David for asking me the easiest question this afternoon. Look, we've heard. I should first thank PA for organizing this forum, this session. It's been really fascinating, and I think the sharing is part of how all of us will continue to grow and learn. You've heard mention already about the issue of policy and how policy itself is needed for governments, or the umbrella governments need to act or used to act. There are instruments in place, as we know, that helps governments to make such decisions about sharing information around surveillance. Sadly, it doesn't work very well. And we had an example a few years ago, and then 15, 20 years ago, with avian, with SARS, with MERS, how quickly information is shared really triggers the action in terms of technology, in terms of innovation, in terms of government action. None of these, because we have to work with sovereign governments, governments make decisions about their population. So it's important to differentiate between scientific action and the political dimension that allows these things to happen and manifest. Many of you might have heard or know about international health regulations, which is the agreements that governments have agreed to share information about diseases as they emerge. That sharing is important because issues around transboundary diseases, it doesn't simply affect one country, and with migration and movements, everyone's affected. And so the idea of sharing is critical. The IHR is currently up for reconsideration. It's being revised, and I think hopefully that instrument is what will put things in place that allows for better sharing of data and specimens that will protect us all. My role in UNICEF, I serve in a regional position which covers East Asian Pacific region, from Mongolia all the way through the Pacific. We work with our country offices, who in turn work with governments. We work in concert with WHO that has a different function. Rukli had asked me earlier, what's the difference between WHO and UNICEF? And I said the answer is that we're taller. She didn't believe me, but it's actually true. But there are different functions. The question for all of us is, how do we work together? So you've heard, even in this room, there's so many different dimensions of work that's taking place. The question comes back to, who is responsible for driving policy? It's a simple word, but there are many manifestations. Policy doesn't make anything happen, but it prevents things from happening. And so looking at the specific areas of work that this requires, the role of WHO, the role of UNICEF, the role of UNDP, the role of all the UN agencies, and their role, the question is, how do we find that perfect clearinghouse so we work in concert, not work sort of in silos, not cooperating and supporting what each other does. On the issue of data sharing, I think that's the part that we'll touch on as well. There are challenges that we face in terms of governments' openness and willingness to share data with others, but even in countries. So as we differentiate between different various income levels of government, for the LMICs, for lower income countries, high income countries, you see this differentiation in terms of capacity. The more we can transfer knowledge and capacity, all of us are protected. And so where we can find ways to at least move information across borders, strengthen capacity, and not simply focus on urban centers. I said this yesterday in my talk, focus on those who are far away from the center. They are as important as those sitting at the capitals. If we strengthen from the ground up, we build stronger systems. The issue of policy, once again, is only as effective as its use, and ways in which we can at least help governments to make better decisions. It helps their population and it helps all of us. So my plea, and I think that which is the part that we try to drive, is to say, how do we, maybe through forums like this, understand better what each other does, find a way to share information, and use that information for those of us with access to government to help to make the agenda, make the case, and ensure that that umbrella that we need in times of crisis is in place and sufficiently solid.
Thank you, Basil. That's really wise words, across your decades of experience. I'm struck by the need for understanding among scientists of how policy is set, and I think that being in this room just helps that. It helps people understand that. You brought up data sharing and privacy issues. That always comes up with disease surveillance, and so I am curious how our two technical colleagues address those issues. So privacy and data sovereignty. What level of information should be shared, and how do you bring up those touchy issues with your partners?
Maybe I can go first. So this is sort of a topic that we do talk about quite a bit in Asia PGI. Genomics does tend to be a sensitive topic. Obviously, there's more sensitivities when it's human genomics, right? We're sequencing a human genome, less so when it's a pathogen genome. But again, there are sensitivities. For instance, when we do things like metagenomics, which is sort of, we're sequencing to see what that individual is infected with. We may potentially sequence out their human genome. We may also potentially find pathogens that are novel, of pandemic concern. And the question is, do we share these? As countries, Basil talked about sovereignty. If sequence information is not shared, then it's very difficult to do the downstream analysis to see to make sense of that data. However, at the same time, it's a national decision whether to share sequences if they've found one of concern. So that's the first one, big one. The second one is, as I mentioned, sequencing pathogens, that sequence information can be used for so much more than surveillance and clinical diagnostics, right? It can be used to design diagnostics, to design vaccines. Now, the question is, if you're releasing a sequence from one country, and it's open source usually, and that information is taken up by a pharmaceutical company, industry partner, then how do we reciprocate in terms of how do we attribute some benefit for that country that has shared the sequence information? Can we also make it accessible, the goods that come out of it in terms of outbreak control and prevention tools? Can we now make that accessible to those countries that have shared that information that led to the design of it? I think those are two areas that we discuss quite a bit, and maybe I'll let Lichin address the other ones.
In Singapore, we take personal privacy very seriously. So unless you are mandated by the Act to do what you need to do, you don't get personal data. So I think that is quite easy to handle when it comes to personal privacy. So when it comes to sharing, I thought all these are not necessary, right? Personal side. When it comes to genomics or data that is not, doesn't intrude into privacy, then it's more rights, it's more IP, it's more sovereignty, as you mentioned. And I think in this kind of setting, it's very important to have respect, a mutual respect that this is your data and I respect it and I do not treat it as my data. So we have got a program, a data sharing program, United Dengue, among some of the countries in our region. So we share data, we share number of cases and location, just a overall, not very specific location. We share sequence data, but I don't publish the data unless we publish together. So I think that is very important, that kind of respect that we give each other. We've seen that in COVID. I think COVID has really turned around as well, how GIS8 really has done very well. People are very proactive in sharing, and I hope that continues. But currently, my my opinion is that there are so many platforms now. How do we, as an infectious disease community, consolidate and start sharing on one platform so that we know where to go to? I just feel I don't know where they are. It's just too many platforms, yeah.
There certainly are a lot, and I appreciate your point about the mutual respect and understanding who owns and the ownership of data. So, well, maybe I'll take this opportunity to ask the audience if they have questions for our panelists. I have some more too, but I want to make sure you get the opportunity to ask those. So, if you have any questions, please raise your hand, and we can get a microphone to you.
Hi, I'm Taslim Arifsir. David, excellent panel. I just wanted to understand in terms of surveillance, both clinical surveillance as well as wastewater surveillance. Are there any global platforms which allow a real-time understanding of either emergence or the prevalence of certain pathogens in a region that is visible for policymakers, for innovators, for many other things? Because many times, the challenge that I'm trying to say, many times the surveillance data is restricted either by the practitioners or the funders, and they do not get visibility to the right, people who can utilize it and do it. And are there any that you can share, any of the panelists can share, so that those global emergence or prevalence data should be available so that people can respond and utilize that not only for research purposes, but actually responding it in time, which are not possibly visualized at the time the surveillance began. So quick question on that. Thank you.
I can go first. If there are platforms, I mean, definitely GSAID is one of them. They also give visualizations as data comes in. There's also NextTrain that also does visualizations. I think that the issue with a lot of those platforms, as Lee Ching mentioned, is one, they don't encompass all the information from the different sources. So, we have a big role to play in aligning potentially and collaborating to get all the information. So we're seeing pockets of information being visualized. Second is that we're not tracking a lot of the pathogens that we should. So it's interesting when we did the Asia PGI, sort of the landscaping, some of the major pathogens that popped up as being important was TB. We don't necessarily have a database sharing or even visualizing TB, right? This is a big burden in Asia. Dengue, there are some for dengue. There are, and GSAID just started their EpiArbo. Then influenza is a big one, and that's there. And then bacteria for AMR, so tracking AMR. And I know that is a tough one as well. Again, I think those are some of the challenges, but definitely we need a better solution.
So yes, they are all over the place, I think. And I think Paul mentioned another one just now, ProMed. So another platform, I think very useful, more event-based surveillance. Yeah.
Maybe I'll mention one side note to that. So one of the challenges of creating a database that is globally relevant is actually defining what the metadata is that should be associated with that. And it's not really well done in many cases. So we're actually funding a group called PHAGE, the Public Health Alliance for Genomic Epi, to look at wastewater surveillance metadata. Like what should be collected by everybody if you're going to do this type of surveillance. And so that should be done for each pathogen, and it's not there yet by any means. So I think that there are platforms. None of them are perfect in my estimation, but I think people are moving in the right direction. The WHO Berlin Hub, that's kind of their mandate, right? Is to come up with some semblance of order of surveillance for these different diseases. Again, I don't think they're there yet, but I think Paula's question.
Yeah, I have a question. We've been hearing a lot about things that haven't quite worked yet, but I think one thing that has worked is poliovirus 2 is gone. And a large part of that was wastewater surveillance, and it was done in very low resource settings. Mm-hmm. So again, I'm not an enterovirologist by any means, but I wonder how come it worked. that I mean, I know there was philanthropy as well that went into the funding, but the fact is that that's the second virus, that's human virus that's ever been eliminated. So how did it work? Does anyone have any ideas, insights, and why we can't do that for other pathogens?
If we had the answers, it'd be gone already, right? No, I'm talking about type 1, type 3. Meaning that the short answer is it's not about the science. There are other things at play that prevents this from happening. If it was purely about the science, if we had a fairly controlled environment, the same would be true for type 1 and type 2. But you see where we're still having issues, geographic locations where it still exists. And I think the question really is, can we overcome these additional hurdles, which are non-scientific hurdles, to address those problems?
And I'll add that your point about wastewater surveillance, it is a very cost-effective tool that can be used in lower resource, non-sewered settings. And I think that's what we're trying to build on for other pathogens. So, certainly polio type 2 is a great example, but I agree with Basil that there are probably many factors as to why that happens. So, I mean, the mutation rate and certainly the vaccines that have been produced play a role in that. But surveillance using wastewater we see as a great opportunity for control of many diseases. All of those have to be defined, and certainly in non-sewerage systems, it's a lot more difficult to define what those what a signal means. But we're in the process of doing that with actually many in the room here. So, any other thoughts?
I just want to add, wastewater surveillance, it's interesting because it not only allows us to do surveillance quite cheaply, it also allows us to track pathogens that are of mild clinical disease that can potentially have more chronic outcomes, like what Li-Ching mentioned for Zika, also for lepto that has a very long incubation period. And once detected, you can actually put in some control measures. So wastewater surveillance is a very strong multi-pathogen surveillance method or approach.
I know Paul is a believer. It was Paul's text to me, why don't we do wastewater? In February, that got me jumping into it, yeah. So yes, I think wastewater is very good. It's non-intrusive. We have done individual blocks and different levels of community, but it's not a silver bullet. It doesn't work for many diseases. We haven't found dengue in it, yeah. So unfortunately, yeah.
One last question before I finish with a few. Oh, please.
Hi, David and the doctors. Thanks for the panel. I think for me, I mean, I look at capital markets, right, basically, and something that I really appreciate in this panel is in some form or other, you're kind of talking about understanding risk in this entire process of disease surveillance, right? And it was really, Dr. Ng, something you said really sparked this question. No program in the entire world can cover all bases. And so it's really vital to have this ability to focus, which is achieved through a risk-based approach. Dr. De Alvis, you mentioned, turning the settings to low and middle income countries involves some risk in entering policy environments that are not so friendly to capital at sometimes. And I think Dr. Rodriguez as well, you mentioned that, the work has to come up from the ground, far away from the capital cities where capital plays. So I think my question really, the gateway, I'm hoping Dr. Ng, you can provide this gateway to answer to the question. What's that risk-based approach looking like? Where are the hotspots of risk from a capital perspective? Because the capital markets presents a risk of gradient of risk appetite as you glance across. Like what are the hotspots of risk? If I were to look at it,
market or disease?
Sorry, disease surveillance. I'm just talking like let's say I was a philanthropist.
Yeah.
For example.
All right.
Like I wanted to understand. Where's the hotspots of risk that you're talking about when you say this risk-based approach exists? Yeah.
So because I work with dengue, I may be a bit different, my perspective may be a bit different from Basil, because dengue is very urban, and urban cities has got lots of, it's very crowded. And I would say risk is in urban cities, tropical, subtropical urban cities where density of people, where there's a huge close proximity of people. So when you have an outbreak, you can get very explosive. So I am sure it applies to many other diseases as well, particularly Aedes-borne diseases, because Aedes love the urban setting. They breed in artificial containers. Everything that we have built for ourselves, our home, our containers, they take advantage. So in terms of mosquitoes, urban is a high-risk area. Yeah.
Maybe I can add as well. I think surveillance, if we want to capture everything, is a very expensive thing to do. But like you said, there are ways to de-risk it. We can do targeting of certain populations, certain scenarios. For example, if we want to tackle the zoonotic pathogen issue, we can go to those interfaces where we have animals and humans coming into contact. There's already a lot of information about where those places are, right? And we do a little bit more rigorous surveillance in those regions. Another approach is really ICUs. So, if we really look at that severe disease spectrum in our countries and really monitor what is causing them to end up in the ICU. So these are ways to look at the very high-risk population and de-risk your process. And in low and middle-income countries where resources are tight, this is how we're de-risking it and reducing the cost, but at the same time making sure we catch those pathogens that are both endemic, but are also pathogens of concern, new ones.
So a very quick response as well. It becomes a bit of a circular argument, right? Because you understand what you measure. What if you can't measure? So if you do a heat map, the heat map is based on the evidence that you've collected. Part of what we're discussing is some of the surveillance challenges that we face. But if you take that sort of glass half full approach, what we do know gives us a chance to act. And then my final point is, when we, among us, we're saying we and you, but my question back is, who's the we, right? And so if we don't identify clearly who is responsible, who needs to act, and that comes with accountability. We're in the same cycle of believing that some things should be happening, but it's not clear who's responsible for making it happen.
Thank you. We have about 3 minutes left. I'm going to ask each of the panelists, just for 1 minute, if you could each tell me where you see disease surveillance in Asia in 5 years. So maybe start with Ruki.
Wow, 1 minute. Okay. I actually see a much more of a multi-sectorial approach for surveillance. Through Asia PGI, we are already working with national governments, academic institutions to push the borders in technologies. We're also working with industry partners. These are very important partners to bring in. We're working with you guys, philanthropists. I think surveillance as we move forward in the next 5 years is going to be more and more a multi-partnership approach. The second one that I'm hoping, this is more of a dream but I'm hoping it gets there, specifically for genomics or whatever, rapid diagnostic, whatever, is that we end up decentralizing, that we can do more pathogen detection and tracking at the community level. And that this information then gets sent sort of to the national level where they can actually monitor. So the hope, and if we can do this, there could be quick action, quick treatment as well.
Thanks. Li Ching?
I think it depends on what we do today. COVID has built up a lot of capability and a capacity in the world. A lot of labs have got PCRs, new PCR, brand new, and well, maybe not brand new anymore, 4-year-old PCR sequencing machine. I was in Ghana and I visited their new BSL, sort of shiny BSL-3 lab. And so because of COVID, we have built up a lot. So I think it's an opportunity How are we going to ride on this capability? How are we going to sustain it? I also heard that many labs have been dismantled. They are no longer testing for COVID, including wastewater testing has been sort of aborted. It would be a pity if we do not take this opportunity to go in and sort of pull a break from that dismantling and sustain it with a regular work, a routine work to keep the system warm. Yeah.
And you have the last word, Basil.
Just to pick up on Li Qing's mention, 5 years from now, I have no idea, but I'm optimistic. If we choose not to forget the pandemic for me is meant to be the accelerator that reminds us that if we don't act, if we don't work together, if we don't collaborate, the same things will happen again, right? And so the optimism comes from the belief that the world will not forget. But history says that we have short attention spans, right? But I think the work that we're seeing, even discussions over the past few days, there's a lot that's happening. And if we keep these platforms where we share and we encourage, and all of us find ways to drive governments to make better decisions, I think 5 years from now, we'll have a different conversation. It's positive. Thanks.
Well said, and I think we are actually on time. I do want to thank my panelists as well as the PAA for sponsoring this. I think it's been a really great discussion, and I'm so glad you ended on an optimistic tone, Basil and Ruki and Li Qing. So again, thank you to the panelists, and thank you to the audience for your attention. So, Stefan, our job is to close this great session this afternoon. Maybe I'll ask you, what were your key takeaways from the different sessions today?
Well, as you said it, your last point was, let's end this on an optimistic note. Mm-hmm. So I think on the first session on dengue, I think, it was actually quite optimistic because there are solutions that can handle it, and they need to be implemented. So, and I think as well on AMR, one of the things I think was very clear is that better diagnostics is really, really one of the key players here for very, very short-term better solutions. Mm-hmm. And then I can ask you the same, because you were monitoring the last session, right? So yes. What's your takeaway?
So I will also key on the optimism. I think that disease surveillance does sit at really the heart of every disease that we're looking at, and I think that there's enormous opportunity and energy that was generated from the pandemic, to do better and to be able to count disease, where it occurs, who it occurs among, and we have to take advantage of that energy. I think that the more we can multiplex, the more we can use surveillance systems to not only detect epidemic disease, but endemic disease, and to better characterize that in not only high-income settings, but in low-income settings. I think that we'll be in a much better place in 5 years. So I'm very optimistic. I think that's shared by all of our foundations. One question that I think you asked of your panel that I think is relevant is, the role of philanthropy as we go forward. We represent, very large philanthropies who are interested in this space. So where do you see that going? Do you see us expanding our remit? Do you see, other philanthropies coming in?
Well, yes. I think philanthropy all over the world is playing a more significant role. And it's because there's a lot of individuals that have whatever business owners, rich families that have concluded that they could do something for the world and given their money to a foundation or done other things. And I think we see a growth in just the activities from foundations all over the world. So I think philanthropy is playing a role today and will play an even more important role in the future. But realizing that, I think it's all about making partnerships, right? Because all the philanthropy put together in the world won't be able to do it and won't be able to replace what governments needs to do, right? So I think that the interaction between philanthropists and science and governments can catalyze changes. What do you think?
Yeah, I agree. I think my quote about it really does take a village is really true. It's not. It won't just be philanthropists who solve this. It's going to be the academics and industry partners who can create and scale either diagnostics or therapeutics or vaccines. And so we can provide catalytic funding, but again, it's not going to be sustained funding. And I think making cost-effective surveillance tools, making cost-effective vaccines and therapeutics, developing new antibiotics that are less costly will be key. And again, from our, I don't want to speak for all philanthropies, but from our perspective, we're very interested in demonstrating in a catalytic manner that surveillance, that looking at dengue and MR can be, there are opportunities to improve that. So.
Yeah, and just, I don't think that size is so important in this, because I think also smaller foundations can play a very important role in if they're defining what they want to achieve and can be really specific on that. And just, if bear with me, I'll give you just a quick story. I think we have just maybe 1 minute's time. Going back to right after the Second World War, one of the international foundations thought we were doing rather poorly in Denmark about infant death. That was the Rockefeller Foundation, and so they sponsored a program in Denmark in some municipalities where they sponsored that there would come out a nurse to the private homes where the mother has just delivered a baby, and they would give advice to the mother how to do things here in the beginning, and that simple action really changed the child mortality and sickness in those municipalities. Just a few municipalities, and when the government found out that it was happening a dramatic change, then this policy was adopted all over in every municipalities in Denmark. So, and that really changed something. And so we are thankful for the Rockefeller action back in, I think it was in '46. But it just shows that it doesn't have to be big scale. It can be smaller scale, but it can actually really have an effect.
Yeah, that's a really good story. And I think innovation can occur at all different scales and scopes. It can be technology, it can be delivery, and I think there's room for improvement everywhere. So I think that you're right to say that there are different scales available. Yeah.
So maybe we should allow people to get on with their next program and say thank you very much to all of you.
Yeah.
Thank you for participating.
Thank you.